Dear students, so this class is about hypolipidemic drugs. At the end of this class, you will be able to know the various types of lipoproteins and hyperlipidemias, and you will know the classification of different hypolipidemic drugs available, their mechanism of action, uses, drug interactions and adverse effects, and also their role in the management of hyperlipidemia. You'll be knowing the guidelines for the use of hypolipidemic drugs in the primary prevention of atherosclerotic vascular disease. Hyperlipidemia is increased levels of lipids in the plasma, and the lipids are always transported as lipoproteins. So this is the structure of the lipoprotein. It is a special macromolecular complex that transport the lipids in the blood. So you can see the core of the lipoprotein contains triglycerides and cholesterol esters, and the polar end contains phospholipids, free cholesterol and apolipoproteins. So apolipoproteins are the structural proteins associated with the lipoproteins. So different lipoproteins have different types of apolipoproteins associated with them. And the lipoproteins are classified into 6 major classes. So depending upon the particle size and their density. And they also differ in the nature of upper proteins they have and the ratio of the triglycerides and cholesterol esters, the tissue of origin and their fate of metabolism. So as you can see here, this is chylomicron and chylomicron remnants, very low density lipoproteins or VLDL, intermediate density lipoproteins IDL, and low density lipoproteins LDL, HDL or high density lipoproteins. Okay, so as the triglyceride content decreases, the density increases. So as you all know, fat is a low density compound, so less triglyceride content makes it high density. So you have chylomicrons or very low density lipoproteins, and you have high density lipoproteins which has less triglycerides. And this is the transport of lipids. So how the dietary fat is transported in our body. So as you can see here, the dietary lipids are absorbed in the intestine with the help of bile acids. So here they form chylomicrons, and this chylomicrons, as they pass, they reach the bloodstream through the lacteals, the thoracic duct, and during the passage through their capillaries, the endothelium bound lipoprotein lipase, they hydrolyze the triglycerides which are found in the chylomicrons into fatty acids, and this pass to the fat tissues and the skeletal muscle, and they are stored here. And the remaining chylomicrons, which are termed as chylomicron remnants, so this contain more of cholesterol esters than the triglycerides. So this chylomicron remnant, which is rich in cholesterol esters, they are transported to the liver, and where they are used in the synthesis of cholesterol. And liver releases VLDL, or otherwise called as very low density lipoprotein rich in triglycerides, into the bloodstream. And this VLDL, again, it is encountered by the lipoprotein lipase which is present in the endothelium, and fatty acids are again released into the fat tissues and skeletal muscles. So this VLDL is again degraded into IDL or intermediate density lipoprotein, which has a very short plasma half-life, and subsequently into LDL or low density lipoproteins. So this low density lipoproteins are rich in cholesterol esters, and they circulate in the blood for a pretty longer time. And this low density lipoprotein are again taken up into the liver through LDL receptors depending upon the need of cholesterol. So whenever the need of cholesterol synthesis is more, more LDL receptors recruited in the liver and more LDL is taken up. And HDL, this takes the cholesterol which is liberated when the cell membrane degrades. So as you all know, all cell membranes are rich in cholesterol. So whenever the cell membrane degrades, the cholesterol which is released into the blood is taken up by the HDL, and again this HDL is transported into the liver back. So this is how the lipids are transported in our body. And this is a table showing the various types of lipids which are constituent in the different lipoprotein classes. So chylomicrons are more rich in triglycerides. So they are mainly concerned with transport of dietary triglycerides. And chylomicron remnants, they are rich in cholesterol esters, and they are mainly involved in dietary cholesterol transport. And VLDL is rich in triglycerides, and they are mainly concerned with endogenous triglyceride transport. IDL again contains more of cholesterol esters, so they are involved in transport of cholesterol esters and triglycerides to the liver. So its main source of LDL. And LDL is rich in cholesterol esters and it transports the cholesterol to tissues and liver. HDL is rich in phospholipids and cholesterol esters, and this is mainly concerned with removal of cholesterol from the tissue. So it is actually a good cholesterol. So what are the consequences of hyperlipidemia? So why we are more concerned about hyperlipidemia? Because it causes atherosclerosis, and increased triglyceride cause chronic pancreatitis, and it also causes xanthomas, deposition of fats in the subcutaneous tissues. And there are mainly two broad types of hyperlipidemia: primary and secondary hyperlipidemia. So primary hyperlipidemia is monogenic, so they're genetically determined, otherwise called as familial or hereditary hyperlipidemias. So there are 5 types of primary hyperlipidemia. So among this, the type 2B, otherwise called as familial combined hyperlipidemia or polygenic hypercholesterolemia. So this is the most common type of primary hyperlipidemia. And secondary hyperlipidemia is mainly acquired. So it is multifactorial or multigenic. So it is mainly due to hypercholesterolemia occurs secondary to hypothyroidism, nephrotic syndrome, and drugs like beta blockers, corticosteroids. And you have hypertriglyceridemia, which may be due to diabetes mellitus, alcohol, gout, and chronic renal failure. And this is the classification of hypolipidemic drugs. So you have 5 broad classes or 5 broad groups of drugs. You have HMG-CoA reductase inhibitors, otherwise called as statins, bile acid sequestrants, otherwise called as resins, lipoprotein lipase activators, or otherwise called as PPAR alpha activators or fibrates. Then you have lipolysis and triglyceride synthase inhibitors, and you have sterol absorption inhibitor. So under statins, we have lovastatin, simvastatin, pravastatin, atorvastatin, rosuvastatin, pitavastatin, and bile acid sequestrants or cholestyramine and cholestyramine, fibrates or clofibrate, gemfibrozil, bisafibrate, and fenofibrate. Lipolysis and triglyceride synthase inhibitor is nicotinic acid, and sterol absorption inhibitor is ezetimibe. So the first class of drug, HMG-CoA reductase inhibitors or statins. So these were the important class of hypolipidemic drugs. So we'll see the mechanism of action. So HMG-CoA, so it is an abbreviation of 3-hydroxy 3-methyl butyryl coenzyme A. and this HMG-CoA is converted into mevalonate, which is the rate limiting step in the cholesterol synthesis in liver. So this statin group of drugs, otherwise called as HMG-CoA reductase inhibitors, so they inhibit the HMG-CoA reductase enzyme, which is converting this HMG-CoA into mevalonic acid, so thereby inhibiting the cholesterol synthesis. So by inhibiting the cholesterol synthesis, it triggers the compensatory mechanism which causes increased recruitment of LDL receptors. So inhibition of cholesterol synthesis causes positive feedback mechanism, thereby increasing the synthesis of LDL receptors so that more LDL is recruited from plasma to the liver. So thereby reducing the LDL levels in the blood. And also it decreases the VLDL secretion from the liver. So HMG-CoA reductase inhibitors or statins inhibits cholesterol synthesis by inhibiting the HMG-CoA reductase enzyme, which is involved in the rate limiting step in the cholesterol synthesis. So apart from that main mechanism, main lipid lowering activity, statins also have different effects which plays an important role in the prevention of atherosclerotic vascular diseases. So the anti-atherosclerotic action is due to many effects of statins other than the lipid lowering activities. So these are called as pleiotropic effects of statins. So you have anti-thrombotic, antioxidant and anti-inflammatory actions. So anti-thrombotic actions is mainly due to increased nitric oxide release, increased fibrinolytic activity and decreased endothelin secretion. And antioxidant activities are due to decreased lipid peroxidation, increased reactive oxygen species production, decreased reactive oxygen species production, decreased NADPH oxidase, increased reduced glutathione synthesis, increased catalase, and anti-inflammatory activities are mainly due to reduction in the neo-intimal inflammation, decreased pro-inflammatory cytokines and decreased chemokines and C-reactive proteins. So these effects other than lipid lowering effects are called as pleiotropic effect of statins, which plays an important role in the management of atherosclerosis. So the important pharmacokinetic property of statins. So all statins are inhibited by metabolized by cytochrome P3A4 enzyme. So except rosuvastatin, which is inhibited by cytochrome P2C9 enzyme. So it has various drug interactions, and also HMG-CoA reductase activity is maximum at midnight. So cholesterol synthesis is more in night time. So the statins are better taken at night time, okay, for maximum benefit, except atorvastatin and rosuvastatin, because they have very long plasma half-life, so it need not be administered at night time, so it can be administered at any time of the day. So the main adverse effect of statins or muscle aches. So this is the commonest adverse effect, and a very rare but serious reaction is myopathy. Okay, so we always see myopathy when statins are taken along with nicotinic acid or gemfibrozil, or when combined with any CYP3A4 inhibitors like ketoconazole, erythromycin, cyclosporine, HIV protease inhibitor. So when statins are combined with any of these CYP3A4 inhibitors, or when it is combined with nicotinic acid or gemfibrozil, so incidence of myopathy is increased. Otherwise it is very rare, but it is a serious adverse reaction. And statins also cause a transient increase in serum transaminases level. So the liver enzymes are elevated, but it is reversible. So once the statin therapy is stopped, it becomes normal. So this is the important, serious, but a rare side effect of statins. So increased level of statin administration causes muscle injury, which causes release of myoglobin into the bloodstream. So this myoglobin, it's going to go and block the renal tubules, which causes renal tubular obstruction and potentially lethal renal insufficiency. So this is a very rare, serious side effect of statins, especially when taken along with CYP3A4 inhibitors or fibrates and niacin. So statins are first choice of drugs for primary hyperlipidemia with raised LDL and total cholesterol levels. So with or without triglyceride levels. Okay. So especially the types of hyperlipidemia with increased LDL levels and total cholesterol levels. It is also used in various secondary hypercholesterolemia where LDL levels are elevated, and this is the first choice of drug for dyslipidemia associated with diabetes. The next group of drugs are bile acid sequestrants or resins. So we have two drugs, cholestyramine and cholesterol. So bile acids contain cholesterol, and these resins are ion exchange substances which binds to the bile acids and increase their excretion, and it prevents the intrahepatic absorption of the bile acids. So what happens? More bile acids are excreted because of this resin binding to bile acids. So as a compensation, more plasma cholesterol are metabolized into bile acids, and it causes increased bile acid synthesis. So this indirectly clears IDL, LDL and VLDL from the plasma also. So basically the resins bind to the bile acids, which causes increased bile acid excretion. So this again causes more breakdown of cholesterol into bile acids, thereby decreasing the plasma cholesterol levels. So though resins are used in the management of atherosclerosis, they are not popular clinically because they are very unpalatable, inconvenient to take. So it has to be taken in large doses, which causes flatulence and also interferes with absorption of many drugs. So the patient acceptability is very poor, so they are not very popular drugs. Next group of drugs are lipoprotein lipase activators, otherwise called as fibrates. So they act via PPAR alpha receptor activation. So this is peroxisome proliferator activator receptor alpha. So these are gene transcription regulating receptors which are mainly present in liver, fat cells, etc. So activation of this PPAR alpha receptor causes increased synthesis of lipoprotein lipase enzyme. This lipoprotein lipase enzyme, it clears or degrades the triglycerides from VLDL, and it decreases the plasma triglyceride level drastically. So apart from increased triglyceride degradation, it also causes fatty acid oxidation. So fibrates are mainly concerned with triglyceride degradation and decreases the plasma triglyceride levels. The adverse effects of fibrates are epigastric distress, loose motions, skin rashes, body ache, eosinophilia, impotence, headache and blurred vision. So as previously seen, when fibrates are combined with statin, it increases the risk of myopathy. So fibrates actually inhibits the uptake of statins. So by inhibiting the OATP transporter, so it increases the risk of myopathy, and they are contraindicated during pregnancy. So fibrates are first line of drug for patients with markedly raised triglyceride levels. So they are especially used in type 3, 4 and 5 hyperlipoproteinemias, which has increased triglyceride levels. The next group of drugs, lipolysis and triglyceride synthesis inhibitor, niacin or nicotinic acid. So as you all know, niacin belongs to B complex group of vitamins. So higher doses of this vitamin has a lipid lowering effect. So this lipid lowering effect is not present with nicotinamide. So it is only seen with nicotinic acid or niacin. So the mechanism of action of nicotinic acid is it reduces the production of VLDL in the liver. So it uh, decreases the triglyceride synthesis. So thereby it decreases the production of VLDL and indirectly decreases LDL levels also. So it actually decreases the free fatty acid release from the adipose tissue. So it decreases the lipolysis which is happening in the adipose tissue and decreases free fatty acid release, and so decreases triglyceride levels and hence decreases the VLDL secretion. So again, niacin is an important drug which decreases plasma triglyceride levels. It also increases HDL levels by inhibiting its degradation. So the two main actions of niacin are decreased triglyceride levels, plasma triglyceride levels, and also increase the HDL level. The most important adverse effect of niacin is flushing. So it causes cutaneous vasodilatation, which causes marked flushing, especially in the blush areas, heat and itching. So this is mainly mediated by release of prostaglandin D2 in the skin. So apart from flushing, it causes dyspepsia, dryness and hyperpigmentation of the skin, liver dysfunction, hyperglycemia, hyperuricemia. It is contraindicated in pregnancy. So the most important adverse effect is marked flushing because of cutaneous vasodilatation. So this occurs after every dose of niacin. So niacin induced flushing is very bothersome. So this can be managed by a few mechanisms. So we can start with a low dose taken with meals and gradually increase the dose as tolerance develops. So this is one way of managing niacin induced flushing. And you can use a sustained release tablet. Aspirin, by its action on inhibition of prostaglandin synthesis, it helps in the reducing niacin induced flushing. And also we have a drug called as laropiprant, so which is a specific anti-flushing drug, so which acts by inhibiting the synthesis of prostaglandin D2. So this has no hypolipidemic action of its own. So this is mainly to treat niacin induced flushing. So it is a wide spectrum hypolipidemic drug. So especially it is used in hypertriglyceridemia since it decreases triglyceride synthesis. The next group of drug is sterol absorption inhibitor, ezetimibe. So it is a novel drug which acts by inhibiting the intestinal absorption of cholesterol. So it interferes with a specific cholesterol transport protein called as NPC1L1. So it is Niemann-Pick C1 like 1 transport protein. So this protein is concerned with the absorption of cholesterol from the intestine. So ezetimibe inhibits this NPC1L1 protein, thereby inhibiting the cholesterol absorption from the intestine. So it has a negative side. Since the cholesterol absorption is inhibited, there will be increased hepatic synthesis of cholesterol. So this can be stopped by administrating statins along with ezetimibe. So ezetimibe alone has very less hypercholesterolemic effect. So it is always used along with statin synergistically. It causes reversible hepatic dysfunction and very rarely myositis. So it is a highly tolerant drug. Ezetimibe is mainly used as a supplement to statin. So statin is always given along with ezetimibe and both have a synergistic effect. So omega-3 fatty acid, so this is mainly present in fish oil. So this omega-3 fatty acids are rich in polyunsaturated fatty acids and they are shown to reduce the VLDL triglycerides. So they are used as an adjuvant to diet for the treatment of adult patients with severe hypertriglyceridemia. So let's see some of the recent developments in the management of hyperlipidemia. So we have CETP inhibitors. CETP means cholesterol ester transfer protein. So this transfer protein is mainly facilitates exchange of the cholesterol esters with triglycerides between the HDL particles and chylomicrons VLDL LDL. So that is the CATP, it exchanges triglycerides and cholesterol esters. So it takes the cholesterol esters from HDL into other lipoproteins and it transfers the triglycerides from other lipoproteins to HDL, thereby converting the HDL into cholesterol rich HDL. So by inhibiting this CETP, the cholesterol content in HDL can be reduced. So we have anacetrapib and evacetrapib. So these are CETP inhibitors which are currently in phase 3 clinical trials. Another recent development is PCSK9 inhibitor. So PCSK9 means pro-protein convertase subtilisin kexin type 9. So this is a protease which binds to the LDL receptor and enhances the lysosomal degradation of the receptor. And this results in low LDL receptor levels. So less LDL is taken up into the liver, which increases the plasma LDL concentration. So drugs which inhibit this PCSK9 or alirocumab and evolocumab. So these are mainly monoclonal antibodies which binds to this PCSK9 protease, thereby inhibiting their action. The other novel group of drug is microsomal triglyceride transfer protein inhibitor. So we have a drug called as lomitabide under this classification. So microsomal triglyceride transfer protein is essential in the formation of VLDL. So inhibiting this protein causes decreased VLDL synthesis. The next group of drug is an inhibitor of apolipoprotein B100 synthesis called Mipomersen. So it is basically an antisense oligonucleotide. So normally this ApoB is an apolipoprotein which is a structural protein of VLDL and LDL. So ApoB is essential in the VLDL and LDL formation. So this Mipomersen, it is an antisense oligonucleotide. So it acts on the ApoB mRNA and inhibits the transcription. So it causes mRNA degradation. So thereby decreasing the synthesis of ApoB100. So which is essential in the VLDL and LDL assembly. So thereby decreasing the VLDL and LDL concentration. So that's all about hypolipidemic drugs. So here are some of the risk factors associated with atherosclerotic cardiovascular disease. So as you all know, hypolipidemic drugs play a major role in the management of atherosclerotic cardiovascular diseases. So males more than 45 years of age female more than 55 years of age, those with family history of premature coronary heart disease, cigarette smoking, hypertension, low HDL concentration, obesity, type 2 diabetes mellitus, they are all important risk factors for atherosclerotic cardiovascular disease. And this is interpretation of various plasma lipid levels according to NLA guidelines, National Lipid Association guidelines. So HDL less than 40 is considered as low, more than 60 is considered as desirable, and LDL concentration less than 70 is optimal for very high risk group, those with coronary heart disease, and less than 100 is desirable for all subjects, and 100 to 129 is above desirable, 130 to 159 is borderline high, 160 to 189 is high, and more than 190 is very high. And triglycerides less than 150 is normal, 150 to 199 is borderline high, 200 to 499 is high, and more than 500 is very high. So these are the drugs of choice for different types of hyperlipidemia. So when there is hypercholesterolemia, there is increased total cholesterol levels. So statins are preferable drugs. And when there is increased triglycerides, in case of hypertriglyceridemia, fibrates and niacin, so these are drugs of choice. And high LDL levels, so statins are always preferable. So statins are mainly the first choice of drugs in the management of high LDL levels. And low HDL levels are treated with niacin and fibrates because they are shown to increase the HDL levels. So to summarize, hyperlipidemia is an important risk factor for atherosclerotic coronary vascular disease. So we have various hypolipidemic drugs available. So the most important group of drugs are statins, fibrates, niacins, ezetimibe and resins. So statins, they are the most important group of drugs which mainly acts by inhibiting cholesterol synthesis by inhibiting the HMG-CoA reductase enzyme, and these are first choice of drug in elevated LDL levels and hypercholesterolemia. And fibrates and niacins are mainly used in conditions with hypertriglyceridemia, and fibrates interact with statins, so you should always be careful when combining statins and fibrates. So niacin has an important adverse effect, so it causes cutaneous vasodilatation and flushing. And ezetimibe and resins, they are adjuvant drugs, so they are mainly used as an adjuvant drugs to statins. So these are all the references. Thank you.